like to do a quick land acknowledgement. I know we're all online, but this talk is taking place under the auspices of groups at McGill, and it is important to remember that McGill and Montreal remain on Indigenous territory. With this in mind, we acknowledge that McGill University, MAP, and the PSA are located on the unceded territories of Indigenous peoples. The Kani and Kehaka Nation is recognized as the custodians of the lands and waters on which the downtown campus of McGill is located. And we acknowledge that this land was not given up, signed away, or ceded to McGill University. Tiohtià:ke, or Montreal, is historically known as a gathering place for many First Nations, and today it is home to a diverse population of Indigenous and racialized peoples. McGill's community learns, works, and lives on this unceded territory. Making this acknowledgement does not exculpate us institutionally, rather it intensifies the need to actively support Indigenous peoples in their struggles for decolonization. And additionally, just so everyone has a brief idea of what MAP is, MAP represents a diverse group of international students and scholars who aim to address structural issues of inequality and injustice in academic philosophy. The McGill chapter was founded in 2018 with the same aim. MAP McGill works to foster community among marginalized individuals. We welcome and offer support to all students, instructors, and staff who wish to cultivate a more inclusive field of study. So for more information, feel free to contact us or visit our website, both of which we'll type out in the chat. I'll just put that in there now. And we'd also encourage everyone to come down to our info session / Q&A meeting that's happening next week, February the 10th, 5:30 to 6:30. We'll be posting the Zoom link on our website on the event page for this talk, and we'll send it along in the chat. Now I'm just going to hand over to Sarah, who's going to give an introduction and talk a little bit about how this is going to go.
Thanks, Navo. So yeah, basically the structure for today will we'll have Professor Venkatapuram talk for about 45 minutes. Then we'll have a Q&A where you're welcome to ask your questions over video using the electronic hand raising function. Hopefully everyone's familiar with that by now. Alternatively, you can put your question in the chat and Celia Adele will moderate the chat and read out your questions from there. We're going to prioritize student questions, so everyone's aware of that. I'll call on students first, but I can say more about that after the talk is given. So without further ado, let me introduce our distinguished speaker today. So Dr. Venkatapuram is a senior lecturer in global health and philosophy at King's College London. He received his PhD in philosophy from the University of Cambridge, and his doctoral thesis formed the basis of his first book, Health Justice, an Argument from the Capabilities Approach. Since then, Dr. Venkatapuram has worked with Sir Michael Marmot, renowned social epidemiologist and chair of the World Health Organization's Commission on Social Determinants of Health. He has published several other works at the intersections of political philosophy and public health, including The Right to Sutures, Social Epidemiology, Human Rights, and Social Justice, Universal Health Coverage, Priority Setting, and the Human Right to Health, and How Should We Allocate Health and Social Resources During a Pandemic? A question I'm sure is all on all our minds right now. So please join me in welcoming Dr. Venkatapuram, whose talk today is entitled Theorizing Justice with Health.
Brilliant. Thank you so much. It's an absolute privilege, and I'm really thrilled and excited to be able to speak to all of you today for a number of reasons. One is that to be asked by students who consider themselves to be minorities of various kinds, but also for me as being a variety of minority in various different kinds, I wish that I had such a colleagues or such a support group or a network when I was doing my PhD. I think it would have been a really interesting and different kind of experience. In fact, I left one graduate program to join, another graduate program precisely because of, I think, what would be sort of linked to my minority status of some kind. But so I think it's really great. And I really also want to sort of extend my thanks for asking me, because you're interested in what I have to say and my interest and my passion, which is health justice and global health justice. And the more people that want to hear my sort of religion, I'm more than very excited to pass on and proselytize. So I'm really excited about that. But I joke about it being a religion. I just would be very interested to have more people interested in health and justice. I think that, you know, in 2021, basically my work has completely disappeared because most of my work was about trying to make an argument for why health is important for justice. Hi, Kristen, nice to see you. And so basically, I don't think I have to make an argument anymore about why health is important for justice, or why health is important, or why health is as or more important than the economy or money, etc. But I think that it would be still important from within a philosophical discussion to present and argue about why it's important and how it's important. Because I think that the actual conceptualization of health and the way that we think about its causes and consequences and inequalities, the way that we understand them then has implications for the way that we reason further about them, but also how we build policy around them and how we have formed beliefs around them and all those other kinds of stuff. So I still think that, you know, despite all of us now sort of saying, yes, we are all health philosophers now, we all know about health equity and we all care about health justice, we still have a lot of work to do about actually agreeing and disagreeing about how we think about these concepts and why these things matter. So I'm assuming that, you know, many of you are not political philosophers, or if you are, that you have not necessarily been focused on health, barring Kristen and her cat. I'm assuming that all of you are sort of generally not as sort of expertise in, sort of are not experts in this area. So I'm going to start basic, and then we will go into sort of more deeper, sort of smaller, fine-tuned, fine-grained debates. And then I think especially I would like to have a longer discussion and sort of talk about questions to clarify, but also future-looking questions that some of you maybe are interested in or should be interested in, and what we can look forward to. So before I continue, I just want to make sure, is the technology okay? Can you hear me okay? Can you see me okay? Everything is okay. And thank you very much for those of you who are showing your faces. It's actually helpful for me to see who I'm talking to rather than a blank screen. Okay, so I have 45 minutes and I'm starting at 3:15 my time. And so I'm going to break down this talk into fairly sort of crude 3 sections. I'm going to start with an origin story about where my philosophy started and why the problem that is that I was trying to solve. Then I'm going to talk to you about theories of justice and how different theories of justice have incorporated health. And then I will make an argument for my particular favored theory or approach to justice and why I think it does better than the other ones regarding health, but also because it handles health better, it's actually better as an overall theory of justice because of the importance of health that it is to people. And then I will also sort of talk to you about what I think the problems are, which, you know, I think require us sort of solving philosophical problems that require us solving. Is that okay? Anyone want to leave? Anyone want to stay? Anyone want a discount on their ticket? Okay. So let me start with the beginning, the problem, the real world problem that brought out the philosophical problem, which is basically, if we think about the kind of, for many of you, this may be sort of ancient history, but for me, it was very much my 20s, which is the AIDS epidemic. And so in the 1990s, if you were living in New York and if you were a young person, particularly if you were a gay man, you essentially were thought that you were going to die any day, and that essentially that you may not make it to your 25th or 30th birthday, because in the 1990s, in the late 80s, 1990s, there was an epidemic, an infectious disease epidemic that was essentially spreading very rapidly among gay men. At that time, what we saw was that it was spreading among gay men. It was thought to be very much a gay man's disease. But as we know, there was also this other thing of like, well, you had Haitians that were dying, and you had hemophiliacs that were dying, and you had homosexuals that were dying. And then the fourth one was, whores or sex workers that were dying. And so this was sort of a weird kind of conglomeration of different groups. But then over time, we recognized that there were routes of transmission, et cetera. But what was interesting, or what was the problem, was that it was not simply a tragic situation, but there was a recognition that the causes were not just simply biological, but that had profound social contextual issues. So, for example, the lack of information, the censorship around the disease, the routes of transmission, and then also there was rules and laws that were interfering with the actual sharing of information, but also the organizing of certain groups of people. So being gay and being able to organize a group would actually potentially put you into trouble, etc. And then there was actually the neglect by government organizations and authorities. So if you don't know, so when in this present day and age, if there's an outbreak and 2 or 3 people die, entire industries are shut down because there's like a problem with courgettes, or there's a mushroom infection or something like that. In the 1980s, the president of the United States didn't actually acknowledge an epidemic, despite over 100,000 citizens have died at that point of time. So he sort of only mentioned it because one of his friends and colleagues was also dying of AIDS, and therefore it was sort of something that he had to acknowledge as a problem. But so the government neglect of a group of people that were particularly vulnerable to a disease or an infection raises questions about equity and social justice. But then at the same time, while that is going on, if you paid attention, you would realize that it's not just gay men in rich countries that were dying. It was also very much poor women in poor countries that were also dying. So whether it be sex workers in Mumbai or sex workers in Bangkok who are women. So there was suddenly all these other stuff that was going on as well. And so my introduction to this whole thing was that I worked at Human Rights Watch as someone who was in New York. I was working as a community activist. Sort of a bunch of South Asians were organizing because we had been told by various people in New York City that the taxi drivers who are South Asian were becoming infected with HIV, but all the community-based organizations for HIV were geared towards gay men. And these South Asian taxi drivers were not gay. They were just, they were straight, heterosexual South Asians, but they were also becoming infected through other kinds of ways. And so we had been organizing different kinds of education programs. And so Human Rights Watch was interested in my background because there were doing some work on the trafficking of Burmese women into Thailand. And what was happening was that HIV was starting to intersect with the way that these women were being trafficked or not. So Burmese women would be trafficked into Thai brothels, but then once they were tested and found to be positive, then they were dumped back on the Burma border to die, essentially. And so then this was also happening with Nepalese women who were being trafficked into Bombay brothels, but then if they were found to be infected, then they would be sort of cast out of the brothels. Then that was kind of stuff. So there was starting to become a global issue here about how HIV was being used as a way of dealing with different kinds of people, and how that was affecting the vulnerability of different kinds of groups. So what I was doing at Human Rights Watch was essentially monitoring the situation from a human rights perspective. And the way that Human Rights Watch works is that it monitors, at that time, the Civil Covenant on Civil and Political Rights. And so my job was try to figure out how to integrate civil and political rights or human rights into this AIDS epidemic. And what happened one day was that essentially I was in the elevator with Ken Roth, who is still the head of Human Rights Watch. And he sort of turns to me and says, "What do you do?" And I said, "Well, I'm working on human rights and the AIDS epidemic." And he said, "Oh, that's interesting. What exactly do you do?" And I said, "Well, I told him." And he said, "That's interesting." But then he says something very interesting. He says, "Well, we actually don't think that there's a human right to health." I said, well, it says so in the covenant, in the Economic and Social Rights Covenant. And he says, "Well, that's true. Let me send you something to read." And so then he sent me this essay by Isaiah Berlin called Two Concepts of Liberty. And the idea is that essentially, Human Rights Watch was established initially as a way of protecting political prisoners of conscience. And so they were very much about civil and political rights, and economic and social rights were very much the bad guys. So it was very much the communist, socialist sort of approach. And so philosophically, this Isaiah Berlin's essay, which I hope that many of you have read, this idea that there's something called negative liberty and positive liberty, and that we should be, as sort of democratic sort of liberals or believers in liberalism, we should be focusing and protecting the negative rather than positive. We shouldn't be making human beings into certain kinds of things. We should actually be leaving them alone in order for them to live the kind of life that they want to live. So this essentially is the impetus for the search for a philosophical argument for a human right to health. And that ends up being what my dissertation is about. But it's really a question about how do you reply to Isaiah Berlin and sort of say, this idea of this negative and positive right, and why you should think about it in some other way. So now what happens is that if you are interested in human rights or in the philosophy of human rights, you get caught in this problem, this idea of negative and positive. And then there's lots of other philosophers who've been working on the philosophy of human rights in different ways. And they don't have a particular interest in a particular human right per se. They're just interested in more in human rights in general. I'm particularly interested in the health and human right to health. And I believe that it's actually somehow more special and more important than other rights and other human rights. And so how do I find a theory or something that can sort of produce that? And so at that time, the most visible argument for any sort of claims injustice to health was by Norman Daniels. And he had written a book, I think in 1986 or something like that, where he made an argument that the way that you get to a claim to healthcare is through a Rawlsian theory of justice. And that if you actually look at the Rawls' theory, and he believes that healthcare is a fundamental resource to the kind of equal opportunity that everyone should have in a Rawlsian system. And therefore, rather than put healthcare inside a list of the primary goods, the way that we're going to do it is sort of look at it from an equality of opportunity sort of thing. And then that healthcare is an important sort of determinant of equality of opportunity. And then he argues that as a result, what we should be doing is ensuring that everybody has health care, and that we should be distributing health care according to this principle of equality of opportunity, right? So you sort of give as much health care as you want from that to equality of opportunity. So I'm not going to go too into critiquing Daniel's, because I'd rather spend a lot of time talking about my positive argument rather than telling you why somebody else is wrong. But I'll come back to Daniel's at that time. But the important thing that you have to remember, or you have to know, is that in the 1990s, there was an ethos, a political ethos that was quite significant, which is that South Africa, so the Berlin Wall had fallen. And as a result of the Berlin Wall falling and the Soviet Union falling, South Africa fell as well. So therefore, there was this huge, incredible feeling that essentially democracy and democratic societies had persevered and had won the philosophical and political battle. And then this is where you get the argument about the end of history, and therefore, we are sort of at this point. But also in the 1990s, there were a significant number of international conferences, UN conferences, that were all about human rights. So you had the Vienna Conference of Human Rights, you had the Beijing Conference of Women, you had the 1994 Conference on Population and Development, which was all about women's rights and women's health, etc. So the 1990s, and Clinton was in power, Blair was in power. This was sort of all about democracy, freedom, free markets, et cetera, et cetera. So you have to sort of also appreciate that at that point, there was actually a lot more interest and a lot more appreciation for human rights. And at the same time, there was a movement going on called Health and Human Rights, which is that a man called Jonathan Mann, with two N's, who used to run the AIDS program at the World Health Organization, left the WHO and then came to Harvard, who set up a program called the Health and Human Rights Program. And what he did is that in 1994, he had invited the great and the good philosophers to Harvard to talk about his belief that human rights and the right to health is an important one, and it's an important one to curtailing the AIDS epidemic. And if you are interested in this, and if you can ever get a hold of the transcript of the meeting, you should really sort of pay attention to it. Essentially, all the great and the good sort of said, it's really wonderful, it's really nice, it's a really great gathering, it's really tragic about what's going on with the AIDS epidemic in the world, but your idea of human rights is actually not a very good one. Human rights don't have any philosophical basis. Human rights are not sort of coherent. Human rights law is actually random, etc. So basically, in all their sort of very nice ways, told Jonathan Mann that actually human rights philosophy, or the philosophy, doesn't have enough support, or can't give support to your belief that human rights are sort of foundational and important and can actually be instrumental in trying to address not only HIV/AIDS, but improve health and health equity in the world. So as a result, he got very upset. But then what he did is that he essentially went to the lawyers. So he turned to the lawyers, and basically the lawyers said, we don't have to philosophically justify the human right to health or human rights, because it's actually international law. And so what you'll find is that most of the work since then has been taken up by a lot of lawyers who simply use a more positivistic approach to implementing sort of human rights and how they approach it. But what's also happened, and this is what the exciting bit is that there also began to flourish more philosophical work around health and social justice. And the reason for that partly is because of what happened at Harvard in the late 1990s, which is that Amartya Sen, Norman Daniels, and other people were very interested in thinking about how their respective theories of justice could handle health given that they think that health is very important. So health turns out to be very important in development and development programs. And so Amartya Sen and Martha Nussbaum, who were developing the capabilities approach, were interested in health, but they're not very specifically interested in health, but they knew that it was going to be an important part of their particular respective theories to justice and philosophy of development. Norman Daniels was also very interested in this. And then also what was happening was that in the WHO, a man called Christopher Murray was developing a new measure of health called the Disability Adjusted Life Year. Just a quick 2-minute sort of sidebar here, which is that most of the 1980s, 90s, the way that we measured health across countries is life expectancy and disease prevalence. So how many cases of a particular disease is there and what's going on? And then how long can we expect an average person in this country to live? And Christopher Murray's PhD at Oxford, I believe, was about the necessity to find a new measure that combines the impact of disease as well as a loss of life years. And this is called the disability adjusted life year, which combines both the morbidity that's due to a particular disease, but also the life of an entire year, or sort of shortened life expectancy. So this new disability adjusted life year was both proclaimed as an amazing evolution and progress, but also immediately criticized for being incredibly short-sighted, for essentially being a very fiercely utilitarian calculus. So it's very much about calculating to the most minute degree the amount of life gained or lost from different kinds of disease or impairments, and then also the quantification and valuation in terms of how much money will this cost, or how much money does this state of life, etc. So there were lots of different kinds of things. So what you had on the table in the late 1990s was that you had a rejuvenated utilitarian global metric. So let me say that again differently, which is that you had a revival of utilitarianism through the DALI metric at the WHO, which was not just sort of, at one nation like QALYs in NICE in the UK, but actually this sort of desire to use it around the world. You had Norman Daniels arguing for his theory about the Rawlsian approach to health justice. You had Martha and Amartya, who were sort of basically arguing about capabilities and how to push forward capabilities as being the object of justice. So those are the three things that I know about. There's other theories that were also sort of underway, and I I have to admit that I don't know everything, and I did not know everything, and I still don't know very much. But so there must be other theories and other theorists who are working on different things, which I don't know about. So what my sort of work has been doing is essentially developing the capabilities approach to health, equity, and justice. And the two sort of, I think, contributions that I would highlight in that sort of approach. One is to conceptualize health as a capability, and two, to bring greater attention to our understanding that health is not about health care, but it's about our sort of incredible determining social conditions on our abilities to control our own body and behavior, our vulnerability, etc., are essentially profoundly impacted by external conditions from the local to the global. And so let me then, I'm going to stop here before I dive into these two aspects of the theory. I just want to sort of give an opportunity for you to breathe a little bit, and also see if there's any questions, any clarifications that you would like me to make about what I've just said so far. None? Everything's hunky-dory? Great. All right. So I'm going to assume that you generally know the outline of what the Rawlsian theory is about, what utilitarianism is about, and what the capabilities approach is about. So what I will do is that I will just start with the problem of the capabilities approach and what was needed to happen in order to develop that in terms of the health. So if you have not done, I would highly recommend that you read this essay by Amartya Sen called Equality of What? It's a 1979 Tanner lecture, and I think it does a really good job where he basically says, all of liberalism thinks that there is sort of, all human beings are morally equal, but they profoundly disagree on everything else aside from that point. And so what exactly does moral equality mean? What is the implications of that? And so he then proceeds to show that different theories of justice have different objects or sort of metrics, as some people have called it, or some people have called it currency. So whether it be resources or whether it be utilities or welfare or basic needs, etc. And he goes through each one of them and shows you what he thinks is wrong with either the sort of the actual metric of that. And then after sort of going through all the different problems, he then suggests, I have this thing called the capability, which I think does a better job. And the idea is that a capability is neither an external good or resource, nor is it an internal state of being in terms of it's not just a psychological state of satisfaction or happiness. What he argues is that what we're really interested in is this idea that we want people to be free, to be able to do some basic things that we consider to be, part of a decent life. And he says, that word that he wants to use is, rather than using the word freedom, he sort of uses the word capability. And the important thing about this word capability is that many of us, when we think about capability or capacity, are, likely to think about a person's internal. When you say a person's capability, you sort of say, well, what can they do? In this theory, a capability is actually both. It's a very explicit identification of both their internal features as well as their external conditions. So let me give you a very simple example that some of you might know of already, which is that if you have, say, imagine a Muslim country, and this is a purely prejudicial example, and you're going to scream at me, but I'm going to give this example. So imagine that you have a Muslim country where women cannot go outside in public. They are sort of expected to stay inside. Now, if you say that, does this person have a capability to travel to the shops, for example, and you say, well, yeah, she's capable, she can walk, right? She can get out the door and go to the shop. And in fact, she has a bicycle. There's a bicycle in the house, and therefore she has both a physical capability and then she's also got a bicycle. But the actual thing is that there are a couple of things. One is that if it is forbidden for women to be riding bicycles, then she actually does not have the ability to travel the long distance to the shop. Or if she culturally as well cannot appear in public outside of her household for a variety of different repercussions, then she's not able to actually get to the shops to buy some food. So the capability is this idea that you have to look at both the internal and external conditions to assess whether somebody has the capability to do that. This is important because many of our policy metrics and even our philosophical theories will actually look at that bicycle, right? So they'll say, oh, she's got the bicycle, she's got that commodity, therefore she's got the capability. Or they will look at her physical functioning and say, well, she's fine, so therefore she has the capability. Or somebody might say, something about the mental state as well. But I think that this capability approach is a much better theory in that it's able to incorporate both the internal and external sort of features of it. And if you're more interested in where this comes from, It comes from a work that Sen and Dres did on famines. And so it seems like a very odd sort of place to begin, but I highly encourage you to read their work or read some of my work where I make the link. But basically, Sen's work on showing that famines and mass starvation doesn't happen because of the lack of food, but because of the different kinds of social and economic conditions that constrain ability of people to access the food. Is what causes famines. And therefore, if you look in the silos to see if there's a famine, a full silo is going to give you a wrong indication. You should be looking at whether people can actually take a basket of food home. And that's what we should be looking at. And that's where the concept of capability really initially comes from. So coming back to the project. So if in around 2000, there's this sort of AIDS epidemic going on, and what we know from Jonathan Mann's work and work that I was doing is that it's not access to healthcare that's the predominant issue here. It's actually the various kinds of social conditions that impact people's vulnerability to the infection. Think about a woman who has no access to property, who has no access to self-sufficiency, who has no control over her body and behavior. All of these things are essentially determining her ability to be sort of her vulnerability or ability to protect herself from a fatal infection. There's also no drugs. There's actually no vaccine. And then in 1996, there's drugs, but essentially it's only for rich people in rich countries. So if you're in poor countries, you don't get AZT or cocktail therapy because it's too expensive. And so, then that means that people sort of simply can't have access to medicines either. So there's a profoundly lot of all these other kinds of things going on, but the model says that health is really about an infection, and it's about a virus, and it's about a solution, which is a vaccine or drugs, right? So the capabilities approach provides us then these kinds of basic resources. Say what we're interested in is not just commodities such as a pill or a vaccine. What we're interested in is the ability of people to be able to be healthy. And the famine example is a really good example because it's basically saying that we want to focus on whether people can sort of be adequately nourished or can nourish themselves adequately in their household, as opposed to just sort of seeing whether there's enough food in the market or whether they're able to get enough food. So, but we can't just do it in terms of, developing the capabilities approach simply by saying, oh, the capability to be healthy is important and this is how it works. The second problem that has to happen is that we actually don't have a very good definition of what it means to be healthy. So then we have this other problem then here is that, how do theories of justice deal with the concept of health and disease and health? So we have, on the one hand, like I said, the DALYs have defined health to be essentially the absence of DALYs, right? So if you don't have a full life year is essentially you being healthy. If you stay alive without any morbidity for 1 year, that's health. And then otherwise disability. And so the aim of a utilitarian calculus using DALYs is to maximize your life years, and that is health. In the Rawlsian theory, what Norman Daniels does is that he uses something called Christopher Bourse's idea of statistical normality. So it's this idea that an organism is healthy if its part and processes are functioning within a range of statistically normal distribution for its age and sex group. Yeah, so we can go into that if you're interested, but just think of it much more. So when you actually go to the doctor and they take a measurement, what they're doing is that they're looking at your measurement and then they're thinking about what is relatively normal for your age and sex group. And if you are in that range, then they'll say you're fine, there's nothing wrong with you. But if you are outside of that range, then other things start to click in and they sort of try to figure out what's going on. So we can talk about what Christopher Bourse does well and what's wrong with it, but that's a different kind of discussion. But I just want to say that Norman Daniels says basically our claims to healthcare then are dependent on you basically being within that normal range. So you get enough healthcare in order to push you back into that normal range of biological functioning. And then you also get healthcare in order to be sort of have life opportunities that are within the normal range of life opportunities within your society. Yeah. So you can start to see some red flags here about what's going on, about what's normal and what's sort of just and equitable and relativity to sort of different kinds of contexts and societies, et cetera. So what my effort and my argument does is that it basically says Boris is wrong in the way that he sort of thinks about health as being statistical normal functioning. And I use instead another philosopher named Leonard Nordenfelt, who's been working on the concept of health and disease. And he argues that the best way to think about health is about what he calls a person is healthy if they're able to achieve some basic functionings, he calls it. And so his idea is that it's not just simply about the presence or absence of various things. It's actually abilities to sort of achieve certain basic sort of core functionings that constitute sort of basic life or something like that. So which is basically a combination of both biological and normative ideas about what constitutes a good life. And what I do is essentially take Martha Nussbaum's capabilities. So she argues that a life or a decent life is constituted by at least 10 basic capabilities. And I say, oh, look at that. Here's Leonard Nordenfelt, who says that health is about achieving basic capabilities. And Martha has given us a definition about what sort of a core decent life looks like. So you put them together and you sort of say, looks like health is sort of this sort of concept of a decent, flourishing life. If someone is sort of has a decent, flourishing life, they're able to do these things. But more importantly, for me, I sort of argue that if you look at this in a much more deeper way, it's that these aren't 10 individual sort of tracks that one follows. It's actually, they're very interrelated and one dependent on the other. And what we really should be thinking about is kind of this health as being one meta capability around these basic core capabilities that you're sort of able to, if one of them gets harmed, you're able to sort of go double back and repair, and you sort of be able to develop, etc. So you can read more about that if you want. So the idea is that my argument is that what we should be thinking about when it comes to claims around health and justice is not the mental state about whether I'm happy with my functioning, not about whether I have enough commodities or healthcare, not about other things, but rather, am I capable of doing certain things? You can sort of be very narrow and say, am I capable of preventing disease in my body? Or if you want to go for this more normative account, am I capable of achieving some basic beings and doings that constitute a decent, flourishing life? All right, so now, because I think that the concept of health has been poorly defined, and I think my argument is correct, then what this means is that other theories of justice, we have to look at their concept of health and disease. And if you find them wanting, then they have a fundamental problem because their concept of health and disease is not very good. Now, if you think my concept is right, then basically you have to replace my concept around health as a capability into these other kinds of theories, right? So then suddenly, rather than focusing on access to healthcare in Daniel's theory, you have to be thinking about health capability and how do you sort of provide a health capability in a Rawlsian sense? Or if you're a utilitarian, how do you provide a health capability even in your utilitarian calculus, et cetera? So that would be one implication. The second thing is that what had happened as I've sort of given you this story about the fact that, during the AIDS epidemic, some of us, or many of us sort of directly working with HIV, recognize the importance of social conditions on our abilities to prevent death and disease. right? Now, many of you, if not all of you, if you've been awake for the last 18 months or 14 months, I don't know what month we're on, 14 months, recognize that preventing ourselves from dying of COVID is not going to be about whether there's a hospital down the street. It's about what we've been able to do over the last year in terms of, have we been able to stay home? Have we been able to have sufficient resources to eat and drink and be safe? Have we been able to protect ourselves from infection by when we go outside, etc.? So these are all external conditions that have profoundly determined our abilities to prevent infection, and they will continue to do so. A vaccine is that kind of magic bullet that basically makes you internally protected. So therefore your external stuff completely stays the same, but your vaccine, and absolutely a vaccine would be, is a godsend and is a magic bullet that can affect it. But it only prevents you from this pandemic, not the next one. Right? And so we still are back to, how do you help people stay healthy? How do you help people ensure that they are not affected by preventable disease? It's not the vaccine. It's actually, we're going to need to talk about their capabilities to prevent disease and to stay healthy, et cetera. Right? So the reason that I'm bringing this up is that Norman Daniels, for example, had a moment in 1996 where he learned about something called the social determinants of disease, or social epidemiology, where he realized, or he learned, that actually the most significant determinants of disease are not access to healthcare, but actually all these different kinds of conditions. So, when you're pregnant, what sort of environment were you living in? What sort of nutrition did you have? Were you sort of fully taken care of? When you are an infant, are you getting enough stimulation? Did you get enough food? Were you protected? What was happening during your year 1 to 2? And then also, what kind of neighborhood do you live in? What sort of house do you live in? What sort of work do you do? What sort of environment are you having in your work? And so this was a revelation to him, that actually health is not just about access to healthcare. And then he says, very interestingly, well, actually, if you use a Rawlsian theory of justice, that theory should actually address most of the social harms that happens. Right? And then he also says, and by the way, over the last 10 years or so, I've been trying to sort of figure out how to do this, but I actually cannot distribute healthcare based on the equality of opportunity principle. So what I think should happen instead is that we should recognize that healthcare, in the distribution of healthcare, actually has some variety of different approaches that are incommensurable. You can't choose one way to distribute healthcare as being, or can't say that one way is better than another one. So for example, some people believe that we should help as many people as possible, as you can see from the vaccine, the way that vaccine is being allocated. Some people believe that we should help those in the greatest need, right? So who's going to die? Some people believe that we should give it to whoever will benefit the most. So who's going to benefit, et cetera. So there's different kinds of criteria. And Daniel says there's no way for us to show that one of these criteria is better than another. Hence, what we should do is that he comes out with a process of decision-making that he thinks is fair. So it's called the accountability for reasonableness. And so he argues that because we have incommensurable principles or criteria, what's important is that we ensure that the process of decision-making is fair, right? So from my perspective, that is not an adequate solution to his problems for a number of things. One is that he argues that his theory of social justice, his Rawlsian theory, somehow addresses all those social determinants of health, and it somehow determines or sort of distributes that fairly. And then his process of fairly distributing healthcare is going to ensure that people accept sort of the decisions and sort of are able to address them. So just quickly, there is a fundamental, I think, I shouldn't use that word, right? So I think he goes wrong in one aspect. One is that the social determinants of health are not positive things. Actually, if you go into social epidemiology, the social determinants of health are actually the social determinants of disease. So when we study the causes of illness and disease in epidemiology, what we're saying is exposure to what has caused disease. So when you look at infant sort of exposures and say, well, the child who got stimulation and love and all that stuff, kept going while the other one didn't. The other one has sort of different kinds of impairments and sort of is, lagging behind, etc. So what you've done is that you've kind of said, oh, it's actually the lack of exposure that sort of caused this disease, or the kind of exposure didn't allow it. So I don't have time to go into it, but I just want to tell you that epidemiology actually studies the causes and distribution of disease. So the social determinants of health are negative, bad things that happen bad. Very few epidemiologists actually study what actually causes good health, right? So that's a whole small sort of growing thing, but that's like my gym trainer knows what causes good health, but my doctor only knows what causes disease, right? So there's a distinction here that we're lost. So, but Daniels thinks that somehow the Rawlsian theory distributes all the good things. However, what we're interested in is the bad things. And this is relevant to now and to our current day, is that people and even political philosophers and theories of social justice philosophers were not able to recognize that basically social cooperation makes us all vulnerable to disease and premature death. Right? So the reason why we're all staying at home is because social interaction is dangerous for us. And this is not just true during a pandemic, it's true all the time. And so this is one of the things that we really didn't get into when we're thinking about social contract theories and social cooperation principles, is that by the mere fact that we are social beings is not only good for us in that we need things to happen through our social interactions, but actually it's also a point of vulnerability and harm. And this is also why we need to think about it. But the Rawlsian theory system does not see sort of social interaction as potentially being harmful, and therefore doesn't address those kinds of issues. So, and the second thing that I want to point out that has become much more clear, and many of you will now get it so that I don't have to sit here and explain it a lot, is that Daniel set up a really great accountability for reasonable process in order to make these difficult decisions, but saying that nothing is tough. But what I hope you saw over the last summer and the rioting in the streets of Black Lives Matter, the argument is that if people are being discriminated in the hospital, right? So let's say that you have a fair process in the hospital when somebody comes in and says, oh, we're really sorry, but we've decided that we're going to not give you the healthcare, the ventilator, whatever, because you're not going to benefit very much. You're really in bad shape. You've already got multimorbidities, you're obese, etc. Right? What the riots in the streets were saying is that essentially, yeah, but the life has been unfair to this person, and you've actually caused the obesity, you've actually caused the multimorbidity. So you're screwing the person during the life outside of the hospital, and then once they get to the hospital, you're basically saying our fair system has basically said that you're not going to get healthcare. So they get screwed twice. Yeah. So you can have a very fair process in the hospital, but if you don't look at actually the outside life course unfairness, then there is something that's going wrong. And this is a profound issue that we're facing, because this is where bioethics and public health ethics and social justice are actually sort of where the rifts are, because so much focus on bioethics is in that clinic and hospital setting and fairness and justice there. But here's what we have is a profoundly unjust environment and society in which this fair procedure is taking place. So how do you reconcile what's going on? So what I think is that the capabilities approach does a much better job at this, which is that we are able to then contextually look at individuals and look at what actually are the constraints on their capabilities to sort of protect themselves or to live a good quality, decent life. We have various kinds of tools to be able to assess, what decency might mean. And so I'm hitting 4 o'clock. I can't believe that I've talked for 45 minutes straight. You can see sort of how much I have to say, but I think that there's a number of problems. And so if you're interested in the ones that I've already identified before many years ago, my book on this is got those problems. But I think that we have some significant kinds of intellectual problems that, I'm sort of recognizing over the last year that it requires us to address. And on a political philosophy kind of idea is that we do not, at a global level, we have now understood that pandemics spread or epidemics spread because of social interactions and social policies and neglect. And it's basically a natural experiment that's showing how different countries have responded differently and how it's actually spread. And this spread is actually in the number of deaths and suffering, right? But the question is that how do you get health to be an important thing that the designers of global institutions care about, right? They care about money a lot, and they've designed the global institutions so that money can, easily, frictionlessly move back and forth. And people call it sort of hyper-globalization because it moves so quickly. But think about how health has been fundamentally sort of affected, and the sort of rawness of how crude the instruments are and how crude the concepts are and how unable people are able to sort of address this kind of stuff. So that's one issue, is how do you make health actually an important part of how global institutions function and design and relate to each other? So that's one thing. The second thing is that we know at a national level that health is not that important, right? So we've seen the debates about, this is about the economy and how do we sort of trade off between health and the economy, and people are trying to make an argument. So we're still there about trying to make an argument for why health is, sort of, aside from sort of saying health is important because no one wants to die, we still have not made a very clear argument as to why health is good for itself. Right? It's always about health as being good for sort of the economy, and we should get people back to work, et cetera. But that fundamental argument that, look, even if the economy is not booming, if people are healthy and living long and good, decent lives, that's a good thing in itself. And then there's also distribution problems that I think are really important, and I don't think there's one uniform answer to. So in terms of the way that we are distributing vaccines is a real reflection about how people have been affected by recognizing the injustice about the causes of this disease, that it's not just simply people behaving badly, but actually this has been sort of caused and distributed by the inequalities and structural injustices. And therefore, people are trying to rectify that through the way that they prioritize different kinds of groups in the vaccine. And it's sort of a hodgepodge of everything, right? And people are trying to undermine it. But I think that just the fact that we're trying to do that is an important thing. And we need to think much more about how do we compensate, rectify, accommodate all these different kinds of lifelong injustices that that result in people requiring healthcare. So there's a lot more to say, but I hope that I have given some indication about why sort of this idea of health justice is really important and where it comes from. I've given some sense about the different theorizing or theories of justice and how they sort of approach health. I've given you sort of the 3 leading contenders. There will be definitely more. I've sort of given you an argument for why we need to focus on the concept of health and disease. I've identified why it's important for us to recognize the social conditions and why they are profound in terms of how they impact our health, but why if we are causing the disease and illness, it's a question of justice that we need to address. And then I've sort of identified some future problems, which I think we require addressing is sort of on a global level, on a national level, and then also sort of these sort of questions around how do we think about distribution and sort of variety of principles in sort of addressing that. So I'm sorry that it was a broad brushed sort of talk, but it's much more about making you interested in health justice rather than sort of presenting a very small finite argument on a particular thing. But I'm happy to do that if one of you sort of finds something particularly interesting. Thank you very much for the opportunity.
Silent applause is always strange, but thank you. That was fantastic. I certainly have a lot of questions and want to hear more about a lot of things. But I'll start just by moderating the discussion. So as I said before, if you'd like to ask your question over video or audio, you can use the electronic hand raising function. We'll prioritize students first. And then you also have the opportunity to write your question in the chat if that's easier for you, and Celia will read it out to Professor Venkatapuram. So questions, Navo.
Thanks so much for that, Professor Venkatapuram. I really enjoyed it, and it certainly got me interested in the issue of justice and health. The question I had was, from the sounds of it, current health policies seem to be sort of this short-sighted, focused on the external physical factors sort of thing. And I was wondering if there were any examples, if you have any idea for what ideal policies surrounding health that take all of these factors into account would be.
Yeah, so I think that there are different kinds of micro and macro policies that are trying to address health from more of a social perspective. I guess you'd call it a social determinants perspective. So just very simple things like, let's start with accessing healthcare. So people who cannot show up to doctor's appointments because they can't afford the bus fare, or their work schedules do not accommodate them to go to the hospital for preventative care. So what people have started to do is that they've started to actually address those things. That says, even when we're talking just about access to healthcare when people are sick, how do we reduce the barriers that sort of from people from getting access to that healthcare when they need it? And this has an outcome, positive outcome in terms of disease prevention or disease control, which we value. Then there are, I think, more distal approaches. So for example, if you have early childhood programs, so many people argue that the most important thing that we can do for social inequality in general is to focus on children and the 0 to 2 years. And so these are both economists and health people that argue that the biggest investment that you can make is sort of ensuring that 0 to 2-year-olds are fed well, sort of have their health checkups and stuff. So you'll see, like in the Netherlands, for example, they take their child rearing very seriously. So you actually, if you have a baby, someone visits you in your home every week. And so some people find this really troubling, and some people find this really actually quite egalitarian, so that every child gets a good start on something like that. So those are two examples. I think that it's a more complicated situation in resource poor settings because there's so many things that are challenging that interfere with good health. But the idea is that if you can do something like, fix the roads so that people have the ability to get to the clinic when they, easy, that's one way of doing it. I think, so those are all different ways that people are trying to address it. There's also, I think, at a macro level, a lot of academics have been essentially arguing for addressing the trade laws. So the WTO is sort of essentially what we're trying to do is impact different kinds of trade laws regarding alcohol, tobacco, high density, calorie rich, poor, nutritious foods, all those kinds of things. So those things have a direct impact on disease in a population. And so people are trying to address those kinds of stuff. And they're losing that battle. So the big battle coming up is essentially how does technology, and particularly Facebook, test all stuff. So, if you thought that fighting tobacco was a difficult thing, imagine what it's going to be trying to fight Facebook and its impact on health and well-being around the world. So, but that's the coming fight. Does that answer your question?
It does. Thank you very much.
Okay.
Okay, so I think Kristen was next, then Nicole, then Jen.
Hi, yeah, thank you so much for your talk. I really enjoyed that. And I have a more clarifying question. When you were talking about like the internal versus external conditions that impact like, access to health and healthcare, I feel like I intuitively kind of understand what the difference is between them. But then with some of the examples that you gave, it kind of became a little bit unclear. And I was hoping you could speak more to that. So for example, when you mentioned like, the current example with COVID, the question is not necessarily like, is there a hospital down the street, but, rather who has been able to stay home and who has been able to protect themselves. Are all three of those considered external factors, or are some of them like, basically what exactly is an internal condition versus an external condition? And is what you're ultimately saying that we need to consider both of those types of conditions, or are you favoring one condition over the other in your theory?
Okay. So let me clarify that a bit more. So I think perhaps, let me start with something that I think we all understand, is that when we think about a person's skills or abilities, we tend to think about what that individual is capable of doing, irrespective of where they're sitting or standing. Right? So we're basically saying internal to their body, like on or within their body, like what can this person do, and what are their skills, what are their capacities, what are their knowledge, etc. And so even we might be able to say, can they run, or can they swim, can they stuff, but you're still looking at the person and saying, can they do it? Are they internally motivated and capable of doing all this stuff? So the concept of a capability is different, because it's looking at the person, taking those internal conditions into account, but looking at them in a situation, in the context, right? So if I am fully able to, sort of essentially, I've got, two hands who are working, 2 feet that are working, I've got everything working, and you say, is he capable of walking across the room? And if you look at me and my body, right, and sort of say, well, yeah, he looks like he's able to walk across the room, there's nothing wrong with it. But if I'm actually being held down by something, right, then that means that I am not capable of walking across the room, right? So that when you say, is he capable, does he have the capability of walking across the room? It's not just the internal stuff that one should be looking at. It's also about looking at their surrounding social conditions and sort of saying, what does that sort of able to do? So why is this important is that when you assess a person's quality of life, for example, right? And you're basically saying, okay, I want to measure their quality of life by looking at, are they physically functioning? Do they have any assets, right? This is how different surveys sort of look at it. They're like, oh, do they have a television in their house? Do they have a bicycle? Do they have any disease? Are they alive, etc. Right? So if your survey can check off those things, that means that they say, oh yeah, well, he's got a television, he's got a bicycle, and he's got no disease, so his quality of life is great. But actually what you want to know is whether actually, does the reason that I might have a bicycle, but I actually can't ride it because I'm considered to be a low caste individual and should not be riding bicycles. Only certain super individuals or high caste people are allowed to ride bicycles. Then that means that my quality of life is actually not that great, right? So I'm missing something if I'm not actually looking at the external conditions of what's going on. And I think that's the idea of a capability, is that what we want to do is be able to combine both the assessment of the internal conditions and the external. It gets complicated because the external conditions can go from the local to the global, right? So if there's a global pandemic, then it affects what I can do, what I'm capable of doing on a daily basis, right? So my capability to go out, so you can say something like, you know, am I capable of going and walking in the park? So if you just look at me and my body, you'll say, yeah, he seems like it. But actually there's a global pandemic on and I can't leave my house, and therefore, so I don't have that capability. Have I beaten that horse to death yet?
Yeah, I guess maybe I'm just like focusing on the semantics a little bit, but I'm wondering, like, the global pandemic, is that considered like an external?
It's an external factor, right?
Yeah.
So there's internal factors and external factors. Capability is you combine both of them to see how they interact, to see if I have that capability or not.
Okay.
Yeah.
Okay, thank you.
Yeah, try it out. I mean, read a couple of things, and then if it still doesn't make sense, come back to me.
Okay, so I also had a question from Professor Voigt, and Vanessa Rampton, I see your hand is up too. So just to be mindful of the time, if we can try and keep the questions as clear and succinct as possible, and the answers too.
Sorry, I will do that better.
Oh, I think we all just want to keep talking. So, okay, so Nicole, we'll go Nicole, Jen, Professor Voigt, and then Vanessa Rampton.
So my question is somewhat similar to the ones that preceded it, in the sense that I'm curious about applicability of capabilities more on a micro scale. So the example that came to mind while you were speaking earlier was the clinical assessment of activities of daily living, for example. So I'm curious if there have been discussions of what a capability-driven paradigm, what its applicability could be in a more micro level setting as it pertains to medicine or social work in clinical contexts.
Yeah, so there's been, so I'll answer that very quickly. There's been growing amounts of work around that, what you call micro level or the individual level. So in something called health technology assessment, which is that there are different people who are trying to understand whether a particular health intervention has the outcome that we want, and then particularly whether we can cost that outcome and see whether we want to recommend its use or not. So one of the interesting examples is that essentially you have two medications and they both have the same impact on the disease, right? So they contain the disease, except one medication makes the individual very nauseous while the other one does not, right? So if you just simply have the current clinical model about does it contain the disease or not, you don't really care about anything else. You just care about the symptoms. So those two things are equal. But if you were starting to think about quality of life and whether people are capable or not, and people say, I really value being capable of having, being able to go outside and, sort of do garden work, or I'm capable of practicing my religion, or I'm capable of sort of meeting my friends, then if you value those capabilities, then the medication that doesn't make you nauseous becomes more preferable. And then you start to sort of actually thinking about how much does it cost and what are the different kinds of stuff. So that's one kind of specific example in which capabilities make a difference to how we do clinical medicine. Yeah? Okay, I'm going to keep that short there, but if there's more, come back to me.
So Jen.
Hi, thank you so much for your talk. It was really interesting. I was wondering if the idea of, so the epigenetics of race, and so this idea that a constant kind of exposure to racism wears you down mentally, physically, and then that this stress can be passed down then to from generation to generation, if that complicates the distinctions between internal and external factors in the idea of capability.
Yeah, No, I mean, I don't think it does. I think that, you know, if you actually sort of look into social epidemiology, this is some of the original motivations for social epidemiology. So, for example, you know, my mentor Michael Marmot, his PhD dissertation was on comparing Japanese men in Japan versus Japanese men in California. And sort of basically the hypothesis was that the more acculturated the Japanese men were into the dominant white culture, the more likely they would get the white people diseases, right? So it's actually, that was this whole thing because people were talking about races. The Japanese race have these particular genetic risk factors and they're very vulnerable stuff. But actually you can see that these, you know, kind of, other kinds of, you know, sort of factors impact disease in a much more significant way. But you might be asking for a much more sort of other question is, there are people that are trying to measure the impacts of racism on health. And those are what we would call social epidemiologists. So I personally would think of it in terms of my concepts is that everybody has a capability to be healthy, or they have a right or a claim to do that. And the racism is a constraint on that capability, right? It's a moral bad. It's an unjust constraint on their sort of stuff. It might be wrong for lots of other reasons, but I'm saying that it actually, once it starts impacting my biological functioning and my mental health, and it's constraining that, then it's unjust because it's a socially created impairment that is stuff. Does that? Okay.
Thank you.
Professor Boyd?
Hi, Sridhar. Nice to see you. It's been
nice to see you.
It's been a while. So I wanted to ask you about the connection between capabilities and health. So in a lot of the examples that you talked about, obviously, so having some kind of health condition can affect the capabilities that we have. So we're restricted in the things that we can do, and that's an important reason for caring about health. But at the same time, in a lot of the examples that you talked about, someone's capability is affected by something other than health. So in the example that you described about the person who can't leave the house because women aren't allowed to be in public, that's not a health constraint. So I guess I'm wondering if ultimately what should drive our interest in health is how health impacts on capability, then if what we're ultimately interested in is capabilities, why should we give, or should we give priority to reductions of capability that are health related over reductions in capability that are not health related? So I guess this is sort of a version of the, is health special kind of question, which I think for, if you're interested in capabilities, it seems that there is a reason for saying actually health isn't special. It's just one of the things that can affect capabilities, and capabilities ultimately what we're interested in.
Yeah, so that's great. Okay, so the way that I would answer that, if I've understood your question, is that I think you're asking this question is like, is health just one of a wide variety of capabilities that are valuable, or is it something that's sort of uniquely special? The way that I've sort of conceptualized it is, if you go back to my conception of health, is that what I said was that health is basically a meta capability to achieve a cluster of basic capabilities to have a decent, flourishing life. So health is this overarching thing that has these different sort of thing that are interrelated. One of those capabilities is sort of like biological functioning, right? So this disease and sort of all these other kind of stuff. So what I was saying is that when you have these different kinds of factors outside externally that are constraining your capability to be healthy, so it's this sort of basic, the idea of sort of being able to live a decent, flourishing life, and it can be affecting, these other capabilities, these 10 capabilities in different kinds of ways. And what we want to do is sort of improve it. But then you're saying, well, that's fine and good. Okay, that's one valuable. But then if your basic sort of health capability or this meta capabilities actually, being affected by something else, right? If I understood correctly, it's sort of, so there's something affecting health that's bad, so we should worry in that. But then there's sort of health, this lack of health is impacting other capabilities, and so is health more important than that? Have I understood that correctly, or do you want me to?
Yeah, basically, you know, if ultimately we're worried about capabilities, is there a reason to worry more about health than about other things that might affect your capabilities?
So what I'm saying is that, you know, one, there's a couple of qualified answers to it. For me, health is about a decent, flourishing life rather than disease, right? So some people are saying, like, you know, if you are, when they use the word health, they're talking about disease. They're saying, okay, look, you know, if you're concerned about the causes of disease because health is, you know, valuable, or are you worried that disease causes you to be constrained in other things and therefore it's instrumentally valuable? Like, which way are you going? So I don't really see why I have to choose between these two things, right? So why do I have to make one rule that sort of governs either one of those two situations? That's one question. The second thing is that if there is a particular situation where those two things do come into conflict, I think that's the more important thing, is for us to say, okay, here's the situation. And this pandemic is a very good example that, you know, what we've done is essentially shut down not just the economy, we've shut down life, right? We've shut down all these dimensions of life. And so the question is, okay, how do we actually make a choice between protecting someone from disease versus also constraining these other things that constitute a good life, right? So how do you make a choice between these two things? And I think that there's different ways of doing it depending on, variety of different kinds of personal values or social values or, whatever. But you need to be able to express those values. You need to be able to deliberate about those values. So one is, why should we make this? Why should there be a rule that sort of says, is health more important than what health allows us to do? Or the second thing is that, why, if we are going to see a situation where that choice is necessary, then I think there are plausible ways of identifying the reasons for that. And so we are living through one of those situations where we are sort of deliberating about them. And I think we can improve the quality of that deliberation to say that sometimes preventing disease is less important than other kinds of dimensions of life that we want to sort of do. But the important thing that I want to make is that I think that I don't do, like, I'm sort of making a distinction between health as being able to have a decent, flourishing life versus the disease focus that some people might stuff. I'm happy to talk about that more, but I think I hope that somehow I made a little bit of sense on that one.
Okay, so Celia, you had your hand up, I think, for the question in the chat. So the question is from Christine. Do you want to go ahead and read that out, Celia?
Oh, sure. Okay. So Christine is, first of all, thanking you for this talk. And she says, I'm continuously interested in finding ways of addressing health inequities, hopefully through my future medical career. But I'm just wondering what your suggestions are for overcoming health inequities at the local level. Where do we even tangibly begin now? And how do you think we'll overcome this?
Also,
so I think that, yeah.
If I can abuse my power as moderator, because I have a question that I think relates to this, speaking at like local level, but also with policymakers. So one of the things that you said in the talk about how bad social policies could be causes of health inequities and disease, et cetera. And so if epidemiologists are looking at the determinants of disease, and then they go to policymakers and say, look, these bad policies or these policies with racist histories are determinants of disease or can be conceived as causes of disease, do you then have to present them with like an alternative, or because it's easy to just say like, take away the racist policy and then health could improve, but I'm not sure that would fully understand how to act with that information. And I guess if social epidemiologists are not offering determinants of health, is that a problem? So I think that relates to this, how do we deal with it at local and policy levels, I hope.
So let me sort of see if I can hit both of those at the same time. So the capabilities approach is really awesome for a practical approach because it allows you to look at a very real world situation and sort of ask the question, what are people able to be and do in their daily lives? So if we're interested in addressing health deprivations, absolute health deprivations, but also health inequalities among individuals or social groups, what we want to sort of look at is that what is happening in these people's daily lives that constrains them from achieving their sort of, that constrains them, that makes them vulnerable to health sort of exposures or something like that. So I think this, this epidemic has been a really great example. And so, I co-edited, sorry, this is an advertisement. I co-edited a book last year with colleagues from the University of Ottawa called Vulnerable. And it's all about, in Canada, all these contextual situations that make particular individuals and groups vulnerable. So whether it be, women who are abused at home, basically, this lockdown has increased their sort of abuse levels. Children's abuse has gone up. Homeless people are not able to gather in places so that they actually become more vulnerable. So there's all these contextual stuff, and policymakers who are sitting in state capitals don't think about context. They think about one rule that they can apply, usually geared towards middle class, nice house, internet, fridge, cash, all of that kind of stuff. And so one of the things that we can do about addressing health inequalities is actually look at the contextual situation of different individuals, groups, and sort of say, what is it that's sort of affecting them, that's causing them to be vulnerable, that's causing them exposure to harm, that's causing them exposure to disease, and how do we address it? And a lot of people just look at it at one person at a time. What we are saying is that look at it in a more group at a time and actually change the social and structural, causes of that. That's actually going to give you more sustained impact for improving health inequalities than giving each individual like a solution to their individual problem. You'll find patterns at a social level that are more important and significant to address. So in terms of the policymaker, it's that kind of same thing. I think we, as people who are interested in justice, have an obligation to at least identify the worst situation and getting rid of the worst situation, right? So, people being murdered on the street by policemen is a really bad situation. And so you really want to make sure that you identify the worst injustice, and you can start working up from there and say, this is really bad, do something about the bad one. But as you go up and you start thinking about actually, so what's the alternative to the harms that are being caused? So we don't just necessarily want to address the harms, but actually proactively produce some good things. And the capabilities approach, believe it or not, has the belief that actually making people more free improves their quality of life and actually is a virtuous kind of thing. So it's not just an instrument, but it's actually the end result, right? So that actually, the ability of helping people be more able and capable actually improves that quality. So you could actually think about what are the different ways that you can engender people's freedoms or capabilities more, right? So what could actually help people do more things, be more, and sort of flourish more, aside from just focusing on what constraints and what's harming people in the most egregious way. Does that, okay.
Yeah, that's really helpful. I have so much more I want to say, but we're obviously over time. So we have one more hand. Hopefully you have time to take this one.
Yeah.
Helena, if you want to go ahead and ask your question.
Yeah, thanks. Thanks so much for the talk. That was really interesting. I was wondering, and you also were talking about this, I think, at the end of your last answer, in looking at these external factors and at these more societal and structurally determined factors. I was wondering what insofar as you also work on those, what your approach there is, and what as in the framework of political philosophy you work in there? I mean, it sounded like you were in this, yeah, more in this liberal tradition, but like incorporating critiques of that from like people like Sen as well. But yeah, so I was wondering what your approach there is broadly, and then also secondly, the fact that, as you were saying, in interacting with people socially, we do expose ourselves to like health risks. Do you think that is also determined by like how we're organized society? In society, I guess. I'm also thinking of like, say, relations of productions here, or like work relations, and if you thought that was relevant. Sorry if that's a bit long. Feel free to like address any of that.
Let me just do that quickly and start with the latter one first. So I think that we need to spend a lot more time as political philosophers understanding that our social contract tradition has been conceptualized as being too benign. Actually, putting a bunch of human beings together creates both harms and benefits, and it's not just burdens of social cooperation. There's actually, great, if you want to think about a potential risk of pandemic as being a burden of social cooperation, or whether it's something else, but nevertheless, you need to think about that in the social contract tradition more. I think that in other traditions we've been thinking about that in other theories, that idea of like there's lots of harms that happen, so lots of relational autonomy and sort of relational egalitarians have been thinking a lot about how relationships are harmful in society, and how do we think about making them less harmful, and what are the kinds of protections that we want to address. So the 0 hours contracts is a sort of small example, but I think that's one of these relationships that we are having that actually is harmful, because it's an incredibly asymmetrical relationship where somebody is quite vulnerable and needy, and what we're doing is basically using them for our benefit. And so this also shows you that in times of crisis, such as a pandemic, these individuals who do not have the ability to say no to work, or their work suddenly becomes considered to be essential without their sort of any kind of say in it, then they actually physically become more vulnerable and exposed to danger as a result of our needs. So I think that we do have a lot of work to do in thinking about that. I hope that people are awake to these kinds of social relationships now much more than they were before. The first part of the question, I don't know if I understood correctly, but I think that so I am definitely of the liberal tradition, but what I'm trying to do is show that even within the liberal tradition we have a lot of work to do, and we have lots of disagreements. But more than that, I think that there is a bigger project here about global sort of approaches. What are we going to do now that we're all connected, and you all feel connected to everybody in the world and understand their vulnerability and understand the shared risks? How are we going to get along in the future, and how are we going to acknowledge our interdependency, and how are we going to acknowledge the unfairness of the existing system, and how are we going to sort of build something in the future? So is it going to be about freedom and capabilities, or is it going to be about something else? And I don't know what's going on, but this is a great way for me to end, because I'm going to advertise something for you, which is that I've put together a group of political philosophers from around the world. It's called the International Resource Group for Global Health Justice, IRG-GHJ. And what we've been doing is essentially trying to bring political philosophy to the COVID response at a global level. And we're trying to help global institutions and identify all these issues. And so this kind of stuff is happening. So what's going to happen in the future? What is the kind of ethical values that we should be identifying? How do we not dominate the conversation from the Anglo-American side and let other people say some things as well? So we are going to, so watch that. There's a website and there's seminars and various things. And then in April, there'll be a conference at Oxford at the Blavatnik School on global health justice. So that might be a place where you might sort of find more about what you have just asked, if I've inadequately answered some of the questions. Yeah, does that sound good?
Okay, thank you so much. That was fantastic.
Good. Well, I'm so happy that I was your first speaker this year. I hope that this bodes well and you have lots and lots of exciting speakers and it goes really well. Lots of luck to you all, and keep in touch. And if I can be of help, please let me know.
Great. Thank you.
Thank you very much. Bye.
Bye.